Thank you to the organizers for having me here tonight. I'm cognizant of the fact that I'm the last barrier between you and dinner, so I'll try not to hold that against me. I want to talk to you tonight a little bit about a technology and what a really good technology can do to change, as I said in the title, cause a change in diagnostic modalities. So I'll start off with a slide to tell you a little bit about Singulex, because the story of Singulex is really intertwined with the story of our technology, and we call it single molecule counting. And we've done several things with this technology through the years, and that really outlines what Singulex has done. On the commercial side, we announced about a month and a half ago that we sold the life science business, which was the first embodiment of single molecule counting technology, to Merck Millipore. So we created a life science business with an instrument called the Arena instrument, which I'll show you in a minute how it works. And so we've been successful in commercializing it in the life science space. I think one of the reasons that here tonight is because we're currently in a partnership with Tecan to develop the same technology into a diagnostics instrument. We have developed, starting in 2010, a CLIA laboratory on site in California, where we have brought in more than 2.5 million blood samples to our clinical laboratory, and we've measured these on a variety of tests that need the ultrasensitivity that our technology affords. And so we've really had this technology validated over the last several years on literally millions of samples in the lab. So we've commercialized this technology twice already. And as I mentioned, we're in the process of working with Tecan to commercialize this in a third area, and that's the IVD space. So I'll show you the instrument that we've developed in conjunction with Tecan. We are on track to start clinical studies for the FDA submission and to launch in the EU in the early part of next year. And the bottom bullet point here, as I said, with this strong technology, we've developed a number of patents, over 65 to date, both around the technology and the application to various diseases and biomarkers. Looking out into the future, one of the pluses of being the last speaker is, I can see a lot of synergies and a lot of similarities between what we could do with this technology and the speakers that have gone before me. We've developed assays for autoimmune diseases. We've developed assays for immunogenicity, and we can look ahead and see the application of this technology also to the point of care space, and those are some of the things that we're working on for the future. So let me explain to you a little bit about our technology and how it works. At its very core, this is really an immunoassay, very similar to the way other immunoassays are run. What Singulex does different is in the back end in the detection technology. So the upfront steps, as illustrated in the three pictures right here, are really the same as with most other immunoassays that you might have run. This is a fluorescence-based detection technology, so we use antibodies. We don't make our own antibodies. That's not the secret of our technology. We buy antibodies off the shelf from commercial sources. And we label those, one with a fluorescent dye and the other with a magnetic bead. We run an ELISA system very similar to how it's run by many other people. We do capture, wash, concentration, mixing, incubation steps, very similar to how typical ELISAs are run. And at the end, we wash and we concentrate the beads, very similar. And what most immunoassays do at this point is they read the overall fluorescence of that remains after the non-bound fluorescence has been washed away. So you get an aggregate glow, if you will, of everything that remains, and this glow is proportional to the concentration of analyte, and that's in a nutshell, that's how most immunoassays run. What Singulex does different at this point is we introduce a low pH elution buffer which dissociates the immune complex away from the magnetic particles. The magnetic particles have another layer, if you will, of non-specific binding that creates a background which limits the sensitivity of many technologies. We pull the immune complex and the dye away from those, and we read those those dye molecules in this elution buffer in one of two ways. The first generation system, which you may be familiar with, as I mentioned, was in a system called the ARENA system. This platform was introduced to the market in 2007 and has been very successful in showing the value of high-sensitivity immunoassays. This is the business that we recently sold to Merck Millipore. And it is the basis for a lot of the patents which Singulex holds. I'll show you in a minute how this works, but it's essentially a confocal detection system that analyzes each one of these dye molecules in a single molecule counting fashion. As a second generation system, and I'll explain also how this works. So again, the upfront piece of the assay is the same, but this elution buffer that contains the dye molecules is read in what we call a scanning system. So let me explain a little bit how these two systems work. So in the first generation system, this is a pictorial, if you will, of a capillary. So as I mentioned, we have a confocal detection system that focuses at a very small, about 5 micron interrogation space in the center of this capillary. If you imagine now the elution solution, which contains the dye molecules flowing from left to right or right to left through this capillary, as molecules pass through this small detection space in the center, they are excited by the laser with the confocal optics and also detected by a very sensitive detector. Any molecule that flows outside of this small space in the center is not excited by the laser, is not detected, and hence we have a very low background because we're looking at such a very small interrogation space. So that's the ARENA system, and it has obviously pumps and a capillary system. One of the challenges of the ARENA system, if there are, it's not that the data is not good. It's produced a number of publications throughout the last 8 years showing the value of the technology, but it's sort of limited in throughput because each sample that you run has to flow through a common capillary. And so it's not necessarily most appropriate for the high throughput environment that diagnostics requires. If I overlay what a typical signal-to-noise graph looks like, if you imagine the y-axis being our fluorescence and the x-axis being time, you will see that we have a very small background. We have a background like everyone else, but it's very small. And because of the confocal optics, when we get a dye molecule that passes through this small interrogation space, it creates a very large relative signal. So we use a 6 sigma threshold to distinguish between an actual signal and our background. And you can see here why we call it single molecule counting, because it's very easy to see when a molecule passed by. So it's really the combination, as I mentioned. We have a bright dye, we have confocal optics that give us a very strong signal. We have low non-specific binding, both because we remove the dye molecules away from the reaction and the magnetic particles, and then we interrogate a very small volume. Our second generation system now, which will be embodied in the Clarity system, which I'll show you in a minute, which we're developing in conjunction with Tecan, has the same confocal optics as the first generation system, but now, instead of having a capillary, the box you see there is the representation of the bottom of a 96 or a 384 well plate. Now, instead of flowing the elution solution through a capillary, we just pipette it into the bottom of a microtiter plate. Now the solution stays put, and instead of having a moving fluid and a fixed detector, we have a fixed fluid and a moving detector. So you can see at the bottom there of the confocal optics, there's a circular arrow indicating that, in this case, the objective rotates, creating a small circle. And then we move the microtiter plate in a square pattern to create a scan pattern. I call it the spirograph pattern, but a scan pattern like this. The combination of these movements happens at the same flow rate, or the same linear flow rate, as the fluid flows through the capillary in the ARENA system. So we're able to use our analysis algorithms that were developed years ago for the ARENA system almost without change in our second generation system. If I go back for a minute, The scanning technology versus the flow technology, one of the advantages that it has is that we're now able to read an entire 96 well plate in less than 25 minutes, whereas the Arena took several hours. As I mentioned, it's compatible with the point of care, and it's also compatible with multiplexing. Those will not come out in the first generation of the Clarity system, but certainly the technology is capable of doing those things. One of the things that you might imagine is important if we're looking up through the bottom of a microtiter plate is that we have a very consistent and clear and low fluorescent optical microtiter plate. In order to achieve these requirements, we worked with Sony DADC in Austria to develop a microtiter plate, and it's shown here, that has very low fluorescent, good flatness and optical properties that allow us to maintain the same sensitivity, if not better, than what we had in the Arena system in our new system. All of this will be introduced to the market next year. As I mentioned, we'll start our clinical studies in the US, and we will launch this system in Europe in the Singulex Clarity system. As you can tell, if you've ever run on a Tecan, it looks very much like a Tecan Evo, and we built upon the backbone of an Evo, both because we had familiar with Tecan by running them in our clinical laboratory and because of the instant reliability that it gets us by building on a platform that has been on the market as long as the Evo has. So whereas most systems, when they're introduced to the market, have to deal with a lot of new system bugs and work-in learnings, we hope to short-circuit a lot of those things by building on an established system, using the established technology of the Arena, using the established technology of the Evo system. We think we'll have very good reliability with this system when it's introduced to the market. And there's just a picture of the inside, and it just shows the work table, which is very similar to, as I mentioned, the Evo system that allows us to do all the upfront pieces of the assay with Tecan liquid handling, and then with our proprietary reader in the back left corner. So that's an overview of the technology, but what I really want to focus on for the remainder of the talk is what have we learned from this technology and how can it influence clinical diagnosis? By having a system that's more sensitive than anything that's out there, we've learned a few things through the years. And so I'll start off with this one. I remember going to cardiovascular meetings as early as 5 years ago when key opinion leaders and physicians were talking about troponin. And for those of you who are familiar with the cardiac market, you know that troponin is a marker of myocardial cell damage, and it's been historically used to diagnose myocardial infarction or heart attack. At that time, 5 years ago, nobody really knew if there was troponin present in healthy individuals because no technology then available could measure it. So there was debates going on as to whether you and I, healthy people, even had any troponin in our blood or not. And this really goes to the point of this slide is troponin assays at that point were able to diagnose disease. If you had a heart attack, your troponin shot through the roof, and pretty much any technology that was out there at the time could tell you, yep, you have disease. But nobody could tell you if you were really healthy. And one of the things that this technology has done, now with our technology, we're able to measure troponin in 100% of healthy, normal people. We've been able to map out this distribution, and I'll show you that in a minute, some of the data that we've obtained from our clinical laboratory showing what troponin values in healthy individuals look like. You might say, why is this important? Well, let me give you two reasons why it's important. The first one is you can rule out disease. If I measure your blood and I see that your troponin is at a low value commensurate with what we see in normal healthy people, I'm able to tell you you're healthy, you don't need to worry about having a heart attack anytime soon. That's something patients would much rather hear than, oh, you have a heart attack. Secondly, it allows us to identify this middle group pictured here in yellow, at risk. So you haven't had a heart attack yet, but maybe you're not at the very low troponin values. What does that mean in the middle? Well, we've got some studies here to show that if you can measure healthy, then you can also tell when somebody's at risk. And that's also a very important thing because if you are unhealthy, you'd still rather know that before you actually have the heart attack. So it enables differentiation between the healthy, the at-risk, and the disease levels. It allows us to identify what accurate reference ranges would look like. Before this, as I said, nobody knew what normal values of troponin were, and there are a number of other biomarkers where that's the case as well. We've shown in our clinical lab with many of the inflammatory cytokines, which are important in autoimmune and other diseases, that before this technology came along, nobody actually knew what a reference range for some of these markers should be, and we've started to publish some of these reference ranges based on the data coming out of our clinical laboratory. And as I mentioned, probably most importantly to the healthcare system is its ability to rule out disease. Why is that important? Because I'll show you a couple of examples, but the diagnostic yield of some of the very expensive procedures that currently go on is not very good, and it's costing our healthcare system literally billions of dollars. What if you could replace some of those tests with a relatively inexpensive blood test? So this could really be applied to any disease area, but because we have the most data and the most experience with cardiovascular disease, I'm going to use that as an example, but keep in mind that this could be applied to the other disease areas that we've heard talked about today. So let's just think about cardiovascular disease for a minute and what the different populations are. There's a healthy population, people that have no problems, no risk, no symptoms, nothing really wrong with them. Hopefully that's all of us. Next, there's risk factors but no symptoms. That might be some of us. Next, there's people that have symptoms of disease, so heart failure or coronary artery disease, but they haven't yet had an acute event. Next, there are people who've been diagnosed with one of those things, and probably at the top of the pendulum, there are the people who are having or have had an acute event. These are the people that typically show up in the emergency department. And as you see from the y-axis on this graph, typically that's where the biomarkers peak out, and where most technologies are able to measure them. And then after an acute event, there's also a population of people who've had an event who now have some form of cardiovascular disease, and there's some monitoring or some checking on these people that needs to happen. Typical immunoassays really work in the rule-in stage. As I said, they can tell you if you go in and you have symptoms or risk factors, they can tell you, yes, you've had a heart attack, yes, you have cardiovascular risk, or yes, your heart failure is getting worse. But you need to be able to measure down at these low ends to be able to rule out heart attack, to rule out if you have heart failure, what's the likelihood that you're going to have an acute event and go back to the emergency department anytime soon? Rule out stress test, rule out other expensive procedures. So let's look at how some of these happen, some of the data that we have in some of these different patient populations that I talk about. So real-world use. This is data from our clinical laboratory. No, it's not a typo. We've tested over 600,000 samples on troponin in our clinical laboratory over the last few years, over 250,000 unique patients. This is what the distribution of troponin looks like in a healthy population. As you can see, most people have very low values in the 2 to 3 picogram per mil range and appear to be at very low disease risk. Let's look at some of the papers that have been published with this technology. So as you see on the left-hand side, we'll start off with the healthy population. This is a study done with the Minnesota Heart Survey. So these are patients in the community, and what it showed was that over the course of 15 years follow-up, if your baseline troponin value was less than 10 picograms per mil, you were 9 times less likely to have a cardiovascular event. So this is really long-term prediction in people with no symptoms yet. Let's look at another study. It's very similar. This is the Framingham Heart Study. So 4,000 patients with no history of CVD were followed. And what they saw was that at a very low level, 2.6 picograms per mil, again, much lower risk for developing heart failure over 11 years follow-up. Again, these values are low enough that if you can't measure the healthy population, you really have no way of doing this study and assessing long-term risk in these patients. One more, this is another study, almost 3,000 patients, again without a history of cardiovascular disease. And what it shows is that patients with these very low values of troponin, less than 3 picograms per mil here, are again at the lowest risk for developing coronary artery disease. So we see that you take a good marker, a good known marker like troponin, where it's known good in the acute space, you measure it much more sensitively, much more early on, and you see that it still correlates with disease, or in this case, the risk of disease. So with these people that have very low values, which is, again, hopefully most of us, we're able to tell somebody, followed for 16 years, imagine getting that news that you're going to be okay for a number of years. It's a great thing to be able to tell patients. Let's move on now to the next population. So this is people with risk factors already. If you look at the typical pathway for a cardiovascular workup, what usually happens is you go to your doctor, your primary care physician, and you either have risk factors or you have symptoms, and he says, I'm going to send you on to the cardiologist to get a workup done. I don't know how many of you have had a stress test or a workup done before, but it's not, it's an uncomfortable procedure, and as you can see at the bottom here, it's also an expensive procedure. Basically what he does is put you on a treadmill, either injects you with a contrast agent or some other method for visualizing your arteries, and as you see, as you go along each step of this pathway, which, assuming that he finds something and you have a blocked artery or a partially blocked artery, you go on for revascularization procedure. The costs really increase exponentially as you go on down this pathway. But what if we could change that, as I mentioned, and either at the primary care space or with your cardiologist, do a simple blood test and to be able to tell you you don't need to go on. Another reason this is important is because, as I mentioned, the diagnostic yield of a stress test is less than 10%. I'll say that again, less than 10% of people who go have a stress test have a positive result, and yet it's costing our healthcare system, just in the US alone, several $billion for a test that is identifying less than 10% of the people. Imagine the savings you could do to the healthcare system if you could rule those procedures out before they happen. So we've done a couple of these studies. This first one was published in the Green Journal just this year, and it's just over 700 patients who underwent stress imaging. What we found was, in people that had a very low value, again down at the less than 2 picograms per mil, so unmeasurable by most technologies, we were able to rule out people with a sensitivity of 95% and a negative predictive value of 92%. If you added the physician's judgment in there, those numbers go way up. As it says in the subtitle to this slide, this alone, if practiced throughout the US healthcare system, would save over $1 billion. One other study that was done, again, this is in the risk factor population, so this is people with rheumatoid arthritis already, which is one of the biggest risk factors for cardiovascular disease ongoing, shows, again, it's a very similar story. People with troponin less than 2 picograms per mil have less than a 5% chance of risk of having significant coronary artery disease, so you're able to rule it out in these patients as well. Let's go on to symptoms now. So these are people who go to the ED thinking, they have either shortness of breath or chest pain, and this is the #1 cause for emergency department visits. So they go to the ED, the doctor takes an EKG, it's negative, so he measures cardiac troponin. Troponin's negative, but he doesn't quite know what that means because it's probably not risen in many cases yet to the level where the technology can measure it. So he waits 3 to 6 hours. The patient sits in the emergency department for a number of hours. They take another troponin. If it's positive, they'll admit them, but if it's negative, again, the conundrum has always been, what do I do with this person? They have symptoms, I'm not sure. By using a sensitive troponin test as the first draw, you're able to unequivocally rule out. So imagine if you go to the ED and measure your troponin, it's low, the doctor's able to tell you within an hour or two, you didn't have a heart attack, and basically every minute that you spend in the emergency department is dollars being spent by you or your insurance company, and it would save a lot of money there as well. We did this study, we published it in 2012, showed that with this troponin and these cutoffs, 100% sensitive and 100% negative predictive value for AMI rule out within 90 minutes. Another study just recently published showed that troponin in combination with another biomarker, in this case copeptin, was able to rule out AMI at the presentation draw. So, very early rule out of these people admitting to the emergency department. These are just some of the things that you can do with the sensitivity that this technology has. Now let's go to the last population. These are people that have already been diagnosed with heart failure. This is a study that we did with the TIMI group, over 3,000 patients with stable coronary artery disease. Again, what we showed, a very similar value of troponin, 3 picograms per mil or less are at the lowest risk for progression. So it's not just for healthy or at risk, it also works in people that have already been diagnosed with disease. And lest you think this is only true for troponin, we started on the next biomarker to show that this is a paradigm, as I said, that not only works just for troponin and in the cardiovascular sense, but can really work for anyone. Any biomarker that has been proven to be good in the acute space, when measured more sensitively, probably can aid in earlier diagnosis and rule out. So one of the markers that we've been working on over the last year or two, and will be part of our initial launch menu for the Clarity system, is a marker called endothelin-1. This is a marker that's found in your blood vessels, and as you start to have coronary artery disease and blockage of the arteries, the amount of endothelin is increased in your blood. We launched this assay in the clinical lab just last year, so we don't have quite as many values for this as we do for troponin, but still over 40,000 samples is a pretty good N, and you can see that we're able to measure the distribution very well with this marker as well. So what does that mean? We've done some early studies with this. This was the PROTECT study, so a small sample, 100 heart failure patients, but what we showed is that if you can measure endothelin and you're less than 6 picograms per mil, you're at much lower risk for progression of disease. It's a similar story to troponin, but now another marker that doesn't come from your heart but comes from your blood vessels. Another study with the Vanderbilt Heart Registry, 200 patients, we showed, again, with a very low endothelin value, we're at the lowest risk for hospitalization. So I think in conclusion, what I want to say is you can see the value of sensitivity, and Singulex has proven it from the clinical laboratory data that we have and in some of the publications that we have, that really we think the future of diagnostics is not going to be in diagnosing disease better, but in saving the healthcare system dollars by telling people that they're healthy and they don't need to go on to some of these expensive procedures, and that's really where we're going to be focused in the future. Thank you very much.